Good morning and welcome to today's webinar. I'm Tom Smith from UC Davis, and today we're going to be focusing on mitral regurgitation diagnosis and treatment with MitraClip G4. It really is my pleasure to work with my two co-presenters today, Burkhard Mackensen from University of Washington, and then Richard Bay from Minneapolis Heart Institute at Abbott Northwestern. I think when we look back at the last 10 or 15 years, and all of us have had the experience of really growing from a standpoint of structural imaging, the development of new tools on the side of the interventional approach, but then has really gone hand in hand with our development of imaging tools. And we've been able to now really approach any part of the heart from a structural standpoint because we have these new developing tools and developing software to be able to show the interventionalists really what they need to see to be able to approach very, very complex structural heart issues. And I think with that increasing complexity also comes a true sense of humility from my standpoint, and from our standpoint as we approach new problems that we may have seen as really so significantly complex in the past. We are forced to learn new techniques and new ways of looking at things, and our brains are constantly wrestling with how to visualize and how to see and how to understand what we're seeing and how to communicate that to the rest of the team. So it's from my perspective just been a fantastic journey in structural imaging, and looking forward to today's discussion. So we'll go ahead and get started, and I'm going to talk about accurate diagnosis, always the first step, and then Burkhardt's going to talk about MitraClip procedure overview, and then Richard's going to talk about post-clip echo assessment. We'll have some discussion in between these topics, and then a little wrap up at the end. But looking forward to today's webinar, and thank you everyone for joining us. So always the first step, accurate diagnosis, and what does that mean? I think we're trying to. What we really want to be able to do is to understand that unique valve. What does that patient's valve look like? And how are we going to communicate that? And how are we going to approach that valve with the different tools that we have, and with the advent of additional tools to address each specific valve? We really are required to have a definite understanding of that individual's valve. Now, this picture on the left-hand side of your screen is a drawing from a second-year cardiology fellow who had done about 30 TEs by this point and done a couple hundred transthoracics. And I asked him, I said, just draw the mitral valve from the perspective of the esophagus. So if you're the TE probe and you're looking at the esophagus, if you're looking through the esophagus, through the left atrium and the mid-esophageal position, what's the mitral valve look like? And I try to do this with our fellows to try to disconnect the understanding of the valve from the image on the screen to actually understand how that TE probe is being manipulated in the esophagus. What does a clockwise rotation do? What does a counterclock rotation do? What does an antroflex, retroflex? How do you, if you're changing the omniplane, how does that alter how you're looking at the valve? And in order to even have that conversation, you need to understand what your model is in your head. And we need to understand what that model is so that we can then use TE to really fully get a good grasp of that patient's pathology. So we want to be able to move from this understanding on the left to more of a general model on the right of what that mitral valve looks like from the esophageal position. So we know how, when we manipulate it, how we're changing how our view is representing what we're looking at. This is just lateral to the clip. This is just medial to the clip. This is a little bit more superior. This is a little bit more inferior. This is a little posterior from the mitral annulus. We need to have that understanding. It has to be kind of seamless between your hands and the brain, and your brain and the screen. If you're looking at patients with degenerative mitral valve disease, it becomes extremely important to understand what part of that apparatus is failing. Is this a ruptured secondary cord? Is it a ruptured primary cord? Is this degeneration at the leaflet tip? Is this was this a prior patient with prior endocarditis? Is this fibroelastic deficiency, or is this a Barlow valve? So having all of that unique understanding for that unique patient is extremely important as we're approaching how to repair that valve. And I love this slide just because it shows you what you're up against for some of these patients. And these are certainly some extreme cases, but the gradation or the diversity of valves that you may come across for each of these patients, and then the approach to them is very, very different. So when we actually take away, sometimes they look a lot more simple on the screen, on the TE probe, but surgically they can be very, very complicated. When we're looking at functional patients, now we're trying to, how is that posterior leaflet? What's the length of that leaflet? What's the tethering? How are we going to be able to grasp both the anterior leaflet and the posterior leaflet at this one location? And trying to predict those challenges as we're moving forward is extremely, extremely important. Also, another nuance is the severity of mitral regurgitation can be more difficult to adequately assess in patients with functional mitral regurgitation. Lower blood pressure, the orifice may be more elliptical as opposed to more round, and we'll get into that a bit later during this discussion, and some of my colleagues as well will discuss some of the different tools to assess regurgitant orifice area. And then in functional, all functionals are certainly not the same as well. You may have a symmetric restriction, or you may have a very asymmetric restriction with this medial pattern pulled way across, and that's certainly affecting the origin of the regurgitation and how you may approach it. The orifice in patients with a functional versus degenerative is often different. And degenerative, it's generally more circular, and functional, it's generally more elliptical. And that's going to really influence how you calculate regurgitant orifice area, with PISA being closer to accurate in that degenerative patient versus in the functional patient, where it may underestimate, and we may want to use additional tools, or we do want to use additional tools to assess that regurgitant orifice. It really comes down to, in all of these patients, every valve is different, is why in that patient does that coaptation zone fail? What is going on with that specific patient, that specific valve? And then how are your interventions going to improve that coaptation zone? And when we look at transthoracic echo, we're not just looking at the color, we're not just looking at the regurgitant orifice, but that your eyes may start there, but then move throughout the entire heart. And we want to see, okay, what do the cords look like? What do the pap muscles look like? What does the LV look like? What does the annulus look like? What does the left atrium look like? So all of those things are going to be attached or connected essentially to that coaptation zone. And they're all going to be influencing the defect in the coaptation zone, and understanding that entire apparatus for that one unique patient is very important to understand how you're going to approach that valve. Where's the failure? Why is it there? What's affecting it? In addition, the patient's blood pressure becomes very important if this is the transthoracic echo or it's TE under sedation. The mitral regurgitation is often easier to quantify in the transthoracic at a normal pressure, as opposed to someone who is sedated receiving a transesophageal echo, where their mitral regurgitation may be less. So transthoracic echo, I just broke it down to our different standard views, and then we're going to use different tools at each location to come up with a severity, so a quantification of the mitral regurgitation, and a reasonable anatomy assessment. Our true anatomy assessment is going to be coming from our transesophageal echo, but we can, is this posterior flail? Is this thickened leaflets? Is this a ruptured primary cord? Is this a restricted posterior leaflet? That certainly will all understand from the transthoracic echo. Then we move on to our transesophageal echo and anatomy and severity. And in this, it's a lot of the approach I'll talk about is really trying to build that model in your head to sweep through that valve, to understand every portion of that valve and valve apparatus, to understand why that valve leaks for that individual patient, why that coaptation zone fails, and then that will help to lead you to how to then intervene on that patient. And in general, we're starting, this is just 0 degrees, just advancing in the esophagus, moving lateral to medial, so moving A1, P1 down to A3, P3. But notice that we're only really perpendicular to the coaptation line at A1, P1. As we move down, we're not perpendicular to that coaptation line at 0 degrees. If some patients image well from one location in the esophagus, or they may have a horizontal heart, and it may be you may not have as much space in the esophagus in which to advance and maintain your image, and then retroflexion, a little bit of additional manipulation, or a 3-dimensional multiplanar approach may be necessary at that point. So from 0 degrees, then here is just our view from an actual patient with severe degenerative disease as we're advancing down in the esophagus. And then we move out to a intercommissural, bicommissural view. And in this view, as opposed to the angle defining the view, the image should define the view. So it's that angle of your omniplane and probe position that allows you to see P1, A2, P3. And then from that standpoint, you're essentially 90 degrees off of your long axis view. And you can also rotate your probe clockwise toward the aortomitral continuity and up toward the aortic valve, and then counterclockwise towards all posterior leaflet. So here's just an image of that manipulation going from the aortomitral continuity to the posterior annulus. And from this view, X-plane is also a great tool, and a tool to be able to take that, if you're at the point where you are right on that line, where you're on that bicommissural view, then X-plane should give you that direct long axis view. And really, if you're in the A2, P2 area, you should be perpendicular to that coaptation line. And then you can move your X-plane on the bicom from very, very lateral to very, very medial, or very, very medial to lateral, basically sweeping along that coaptation line to see the regurgitation at each location. Just keep in mind that that coaptation line is curved and going more anteriorly as you go more lateral and medial. So your actual grasp view is not going to be defined by this long axis view as you move more lateral or more medial. Certainly in the A2P2 it will, but as you move further to the extremes toward the commissures, it will not, because you're no longer going to be perpendicular to the coaptation line. And that's where NPR can be very helpful from that standpoint. So here's a long axis view, which is just going to be 90 degrees off of that. So if you got the bicommissural view at 45, then you're going to be at 135 for your long axis view, and this can help you to anticipate your grasp zone, grasp view here, and then a rotation from counterclock to clock as we sweep from lateral to medial all along that coaptation line. It's going to basically give you the same data that you got from your X-plane view of the bicommissural view. And then when we're dealing with patients with FMR, then it's really understanding how taut those leaflets are, where they're closing, and the ventricular displacement of that closure. If you're where your coaptation zone is no longer existent, with that, in this case, with that posterior leaflet that's very, very restricted, what the length of that posterior leaflet is, and that's going to influence what type of device you're going to choose for that patient, and then how eccentric or elliptical that orifice is on this patient. So and then we bring it all together with 3D, and we understand the anatomy and the shape and the location of the jet with 3D, both with and without color. And this really helps for communication in the team. So we're moving from our own model, we're sweeping through the valve and building that model so that it's unique for that one individual patient. And then through our sweep, we basically build this matrix in our head of what the mitral valve is for that individual unique patient. and then we can help to communicate to that to the team. Now, NPR is just a tremendous tool that's been available for a few years on some of the systems, and certainly is available on all the systems currently. And this really allows us to go from 3D back to 2D. So if you have a three-dimensional, if you're unable essentially to create a two-dimensional image of say a perpendicular grasp line, you can take this multiplanar and rebuild the two-dimensional image from the three-dimensional image. So it's a very, very powerful tool, and it can be, and you can use it in real time to help with valve assessment, but also during procedural, during the procedure and follow-up. Mitral valve area is also obviously extremely important for to assess in patients prior to moving forward with repair, and NPR is very helpful in that from that standpoint too, where we can make sure that we are finding that that smallest area to measure. Now, something that I think all of us are probably going to be talking about is the use of vena contracta area, and when we talk about that round, more of that round orifice for the regurgitant orifice of a patient with degenerative disease versus more of that elliptical orifice in patients with more secondary or functional MR. What we see, this is the exact same patient, and for a regurgitant orifice area, we're getting 0.4. For vena contracta area, we're getting 0.8. So vena contracta area allows us to use that NPR in a 3D color volume and trace out essentially the orifice area. So that the tools have gotten so good now that we're able to take that essentially to actually measure the orifice area, and we're not limited by the PISA limitations with an elliptical, or we're not limited by the PISA limitations of a hemispheric assumption. So in patients with functional MR, vena contracta area is certainly more accurate, and it's just some data from that Paul had presented a few years back. And Dr. Hahn refers to that the convergence is not as hemispheric; it's ergonoid in shape. A wonderful word that I try to use as much as possible. But there are quite a few PISA limitations in patients with functional MR. So keep that in mind when you're trying to quantify the severity of MR in patients with functional disease. And then the grading of MR is a integration of many different assessments. So it's not just pulmonary veins, it's not just color. There are a lot of different nuances from the eccentricity of the jet to the blood pressure to the pulmonary veins, and all of those have to be integrated into assessment of into your assessment of the severity of the mitral regurgitation. But some of the main things to certainly keep in mind as you're moving forward in your assessment is what assumptions are you making, say with PISA versus vena contracta area. So I think the diagnosis, the accurate diagnosis, really comes down to having the best understanding of that individual valve and being able to communicate that to the team, and that helps to greatly influence how you're going to approach that individual's valve. So just a brief summary. We're building that model, sweeping through the valve, and anticipating how we're going to repair that valve. Richard and Burkhard, are you now still doing many of your pre-procedure TEEs, or are they generally coming in with TEEs from the referring practices?
For our group, I think that we are doing the majority of the screening TEEs. It's not necessarily me personally. I think we have done enough of these over the years that all the TEE physicians in our group are familiar with the protocol. But we do get probably a quarter of the patients are referred from elsewhere with a TEE with them. And if it's of adequate quality, we can certainly just go by that. But there are still some smaller places with less experience that we end up having to repeat the TEs.
And for us at the University of Washington, I can say that for the majority of patients, we will end up repeating a TE pre-procedurally here at the institution. But it really depends where they're coming from. If they're coming from a site that is involved in MitraClip procedures, then often the quality is impacted in a positive way. What I think is key is to make sure that those that provide the intraprocedural imaging are helping with the establishment of a protocol and make sure that all the key components you just alluded to are really represented in that initial imaging.
When we're screening these patients and trying to understand how we're going to repair the valve, some of the challenges with, say, post-clip gradient come into play. And I think that certainly a pre-procedure gradient is important from the standpoint and valve area, which we can know if we're above 4 square centimeters, and if our gradient is not significantly elevated, then we're generally we can generally be successful in placing the necessary clips to repair that valve. But there are some nuances in valves where you may say, oh, I think this patient actually might have a higher gradient after repair. And I think that we may see that with more stiffened leaflets or more thickened leaflets and a little calcification in the almost these cardboard appearing leaflets. I think but it sometimes can be a challenge to really determine which patients going forward are going to have that gradient of 6 or that gradient of 3 after that clip goes in. Are there other specific things that you look for, Burkhard, to predict that?
Yeah, so I think really important in the context of looking at the pre-procedural valve area and the suitability of repair with the MitraClip, especially when we're thinking about larger clips and the wider clips, is to really assess the valve area, take into account when you do your gradient measurements, what the heart rate is and the status of the patient. Are they deeply sedated, or are they intubated, or what's their general anesthetic or sedation status? But most importantly, the heart rate, obviously. And then I would say we've often been surprised with significant gradients that were maybe in the 3 to 4 millimeter mercury or even higher range before a MitraClip intervention, with severe or outrageously severe MR, and then seeing that gradient come down as we actually start treating the regurgitant orifice. So I think that's important to keep in mind. So in summary, I believe it's important for the interventional team, the structural heart team, including the imagers, to ultimately really sit together and make a decision on each patient.
Yeah, absolutely. Communication and then that shared knowledge that comes from working through these patients is invaluable moving forward. Burkhard is going to present a section on the procedure overview and optimal TE views for a successful procedure. So, Burkhard.
Thank you very much. I believe that we just learned a whole lot about the importance of really understanding the pathology and the mechanism of disease before we go into what we hope is a successful MitraClip procedure. So with that, I'm going to quickly summarize what we need to consider for a stepwise approach when we guide the MitraClip procedure, be it a generation 4 MitraClip or earlier generations. We need to have a comprehensive assessment, as we just learned and talked about, to understand exactly that precise pathology and the severity of MR at baseline before we treat. The transeptal puncture is our moment to shine, as we need to always be looking for the transeptal needle to ensure that we have no injuries and then we have a precise spot where we go across the septum. And I'm using biplane and 3D guidance for that. Then obviously it's about guiding the guide delivery system and the clip coming into the left atrium, advancing off the whole system into the left atrium and ultimately into the left ventricle. And then the orientation of perpendicularity in concert with a clear understanding of the pathology that we're treating, and then certainly leaflet capture and grasping, as well as the comprehensive assessment at the end of each grasp and each delivered clip. Now, with this next slide, I'm briefly talking about the fact that we're using biplane imaging or perpendicular images in order to understand an inferior versus superior position, as you see with the bicaval view on the left upper, and then a posterior versus anterior position with a short axis view of the aortic valve. Now, 3D can help as well, as you see it on the right upper. And I think in our ability to not only apprehend the 3D, but also understand it and use our live cropping tools, we are much more versatile in using 3D to guide the transeptal puncture. Ultimately, we need to have sufficient height above the mitral annulus, as you see in the right lower image, and that could be measured out in a 4-chamber view or an inverted 4-chamber view, or in using a 3D image that then you crop into. And I'll talk about some of those opportunities. The next slide here shows one aspect of biplane imaging, which is it's important to understand that as soon as you rotate your multiplane angle on your original image view above 90 degrees, your perpendicular biplane view will actually be inverted. That's not a problem, but it's important to understand it and then communicate accordingly with your interventional proceduralist. Now on the left-hand side, you see the bicaval view and a perpendicular inverted 4-chamber view that shows the tenting quite well on the right side image, but not as well on the bicaval orientation. On the right side image, you see the aortic valve short axis view quite nicely at a little bit of a higher angle in a rotated heart, and then the perpendicular view on the on the right-hand side, which is more of a bicaval orientation. So when we guide the transeptal puncture, it's important to use biplane imaging. And as we see on these couple examples, it is important to understand the multi-view and the multi-view angle or multi-plane angle on the initial image that you set up, because as soon as that angle is exceeding 90 degrees, you will have an inverted view, as you see on the left-hand side of the screen. On the right-hand side, you see a beautiful illustration of a short axis view for the aortic valve and a good tent in a very thin portion of the septum. And then the right side image is rotated forward towards a bicaval view in this example. This next set of images is from our Center for Cardiovascular Innovation, where at times we have the great opportunity to put together fluoro images, 2D and 3D images with TEE, as well as a camera that resides inside of a cadaveric model. So when you look at these images in concert, it helps to really conceptualize the fact that yes, we're going with a needle that comes from the IVC, as you see in the right lower example, and goes against the septum in sometimes a pretty tangential angle, but in this example, you see that we're actually achieving a pretty good attack angle, if you will, towards the septum, and then the tent will form quite nicely here in a bicaval view. Now I'm adjusting the plane and I'm seeing a good short axis view, again, this being inverted with the tent now relatively anterior, so we do have to move more posterior in this example. And having the fluoro image in the same set helps to really understand each other's difficulty, if you will. Moving on, I'm quite often using 3D imaging, especially as a quick live capture if I have difficulty finding the transeptal tent in a 2D orientation. And here on the left-hand side, you see such a rotated live 3D image where the tent shows up in the fossa in the thin portion. And I can also use then a cropping plane to really get into that point where we have the transeptal and the mitral valve annulus in a good 2D kind of deconstruction in a way. And then that allows me to get a transeptal height. Moving on, in this example, you see the orientation of the SVC, the IVC, and then the tent in concert with the mitral and aortic valve. And I want to point out the position being posterior, mid fossa, and in a good height posterior, because here we have the commissure that is the posterior medial commissure of the mitral valve. So we have a nice position above that commissural point, with anterior being on the left, indicated by the aortic valve as well as the SVC. Now, once we have that transeptal puncture, we certainly follow with the guide catheter. And I'm showing here, again, an image from our cadaveric setup where you have the transeptal puncture illuminated, as well as the right side image, which is a 3D en face view, really showing that point of transeptal puncture and the guide delivery system being across in the left atrium. Now, if you have the opportunity to get a big enough and large enough volume, you can follow the guide of the clip and the clip delivery system down to the valve in these steps, as you see here, navigating anatomic landmarks, such as on the left-hand side, as it replays here in a second, the left atrial appendage, the Coumadin ridge, and other structures that are important to navigate. Often I'm using 3D imaging as a live image if I have the opportunity to get a large enough volume to really in real time guide the advance of the clip and the clip delivery system down to the valve. And as you see on the left-hand side, there's the left atrial appendage would be here. We see the Coumadin ridge, and the clip is actually quite advanced. So it's good to have everything in view, including the transeptal puncture side. So as I'm playing this, you see how in a stepwise fashion, we're navigating the Coumadin ridge and then coming from anterior lateral towards the center of the valve, certainly then still being above the valve, as I show now from a side view, and then we can open the clip in order to look at initial perpendicularity or other items that are important to consider. This basically shows this in a few quick steps. I'm not going to spend too much time. I think the point is clear that once we are above the valve, we need to look for perpendicularity of the clip. And again, as Dr. Smith actually mentioned in the initial talk, understanding the pathology will drive the perpendicularity that we need to achieve. Now, for next step, I wanted to throw this aspect in, which to me is quite important. If we're using biplane imaging with a commissural view on the left and the resulting long axis LVOT view on the right, then it's really key to understand which angle we need to achieve for our biplane imaging with the commissural view. And as our patients not all have the same rotation of the heart, I'm using live 3D imaging as I showed on the right-hand side, where we have a multiplane angle of 60, for instance, but yet we can appreciate that the commissures are not perfectly cut, meaning we're cutting through the anterolateral commissure, but not really through the posterior medial commissure in this example. Of note, I should point out that this 3D image is just shown as it comes up if I go between 2D and 3D imaging. So this is not an en face orientation. In fact, the posterior annulus is on the top of the image. Now, if I change the multiplane angle in my 2D image, we can appreciate how in 3D now we're cutting through both commissures, and both the anterolateral as well as posterior medial commissure are in view. And I think for the rest of the procedure, I'm pretty confident I can use this 80-degree angle in a bit of a rotation of the heart as my baseline bicommissural view to then use biplane imaging and get a nice long axis view on the right-hand side. Now, as we're talking about the MitraClip Generation 4 system, I want to remind ourselves that we have 50% wider clips in the grasping area. And we also have these two lengths of the clip arms where we need to look for insertion of sufficient leaflet of up to 9 millimeter leaflet length for the larger clip, which extends to 12 millimeter for the clip arm, or for the NT size, which is 9 millimeter, we need to have at least at minimum 6 millimeter of leaflet insertion and therefore leaflet length. That's just important for the frictional elements to really have enough leaflet contact. There's a few additional changes I just briefly wanted to reiterate. One is the continuous left atrial pressure measurement within the steerable guide catheter, which for us at our side has certainly reduced the role of the PA catheter, thus making the whole procedure less invasive. The controlled gripper actuation helps to independently or simultaneously grasp. I will talk about that in a second. However, in our hands, or based on our experience, we suggest to use it with caution. The clip may actually change its orientation and therefore the perpendicularity once you have one leaflet in the clip with the grasp. And then the other aspect is that you certainly can put a lot of tension on these leaflets as you grab one leaflet and then try to go posterior or anterior, depending where you started. There are certainly a few other aspects that are not relevant for my talk, including more simpler preparation and parts of the procedure. To highlight that testing of the controlled gripper actuations, it appears to me quite important to look at both grippers before we advance the clip into the left ventricle. Here you see this gripper on the posterior side moving, and so we can identify the posterior and then the anterior gripper. Make sure that the function is checked before we go into the ventricle. Now, the next slide will show a moving image of this image, which really indicates the utility and the ability to image carefully how we're using the anterior gripper first and then moving the clip posteriorly to grasp a posterior leaflet. So I'm showing this now in the live image. The anterior gripper again is already down and the leaflet is kind of sandwiched between the gripper and the clip arm. And then on the left-hand side, we're trying to make good contact with a posterior leaflet. And then ultimately the gripper is coming down and we seem to have a nice sandwich there as well. Get that posterior leaflet in here. It's showing it again one more time. Certainly paying close attention to posterior now while we have the clip move towards the posterior annulus to accomplish the grasp. This is a 75-year-old male. I'm not going to all the details of his history, but suffice it to say that the patient presented with an anterior leaflet prolapse for treatment of percutaneous treatment of the mitral valve. He had an extensive surgery with aortic dissection in the past and therefore was not a great candidate for repeat surgery. As you see on the left-hand side, there is a significant and very broad-based MR jet that is going posteriorly with this anterior leaflet prolapse. The right-hand image shows the vena contracta from the left ventricle, again showing that it's essentially going commissure to commissure. Moving on, here is an example of a quantitative assessment that was mentioned by Tom initially, a vena contracta area of 1.1 centimeter squared, certainly again illustrating the length and the shape of that footprint of the MR, indicating that we probably are going to need more than one clip to treat this type of problem. Further quantification of the MR at baseline in brief terms showed an effective regurgitation orifice of 0.46 and a significantly eccentric jet posterior. And there's certainly complementary findings on the pulmonary venous assessment. Now, in our multiplanar real-time imaging, we show on the left-hand side convincingly that we, with this first grasp, as we bring in an XTW for sufficient grasp and a sufficient reduction of this vena contracta area, we look for orientation of the clip. Now, for this particular problem, we selected to use an XTW clip to start the procedure. We felt we had sufficient leaflet length and sufficient mitral valve area in order to start with that clip. And we also knew that there was a significant regurgitant orifice where we were hoping that the width of the XTW would help to reduce the regurgitation. The left side image shows quite convincingly that with the first XTW grasp, where the clip is still associated with the delivery system, and we can already identify in the short axis on the left lower, as I'm pointing out here, basically a creation of a figure 8 as we have both leaflet solidly in the clip that is now closed. Now the 3D en-face and ventricular view on the right-hand side illustrate remaining MR from both sides, both lateral as well as medial. But when we look especially and flip that image around, we can learn that the medial orifice seemed to be larger and therefore potentially the better target for a next clip if we were to think that that was necessary. Further assessment with 2D color and 2D biplane imaging as illustrated on the left, and then again using 3D as you see it on the right-hand side to convince ourselves that in fact there was remaining pathology, in this case anterior leaflet prolapse along with the original pathology. We decided to add another clip in order to further reduce the MR. Now this next image shows how we progressed. For the second clip, we decided to use an NT clip only. We didn't want to further reduce the mitral valve opening area unnecessarily. We partnered that NT clip as close as possible to the initial XT clip, XTW clip. And you see on the left-hand side the grasp. There was not a difficult grasp at this point because both leaflet had already been approximated quite well. And then the right-hand side shows the deployed state, again, with a figure 8 reminiscent of a transgastric view in the left lower aspect of that multi-view imaging. The next slide here shows the final result. The forward gradient was only 2 millimeter mercury. There is 2 jets that can be appreciated, but if you look and flip that image around, the 3D with color shows that the vena contracta area and the orifice for these jets are really, really small. You have to look quite carefully. And convincing evidence of the normalization of the pulmonary venous flow on the right-hand side showed us that we really achieved a very nice and sufficient result. 2 more images just to show the baseline on the left, again, illustrating how important it is to have good baseline documentation of the severity of MR and then the final result on the right-hand side. So in summary, for this case, we certainly have a successful procedure with 2 G4 MitraClips, in this case, using a somewhat unusual combination of an XTW with an NT clip to treat this significant anterior leaflet prolapse. We had a successful reduction of MR, and the remaining MR was certainly no more than mild, potentially even trace. And the inflow gradients were quite nicely low despite the use of 2 clips. So now I'm going to summarize briefly what we talked about, and we will also have opportunity for discussion, but certainly it's important to consider a stepwise approach that is really key for successful procedural image guidance. It's also essential to use all of your 2D and 3D skills to not only assess the mitral valve comprehensively, but also guide the procedure at times with 3D and biplane imaging. It's also important to keep in mind that we ought to think ahead in terms of our procedural image guidance, kind of always anticipate what might be the next step that the interventional proceduralist is actually planning to do, and how can we get ready for that next step. I think the one case I shared illustrates the opportunity to really tailor our repair with various combinations of clips, including the XT, XTW, NT, and NTW, with 2 different lengths of the clips, but also various width of the clip. Multiplanar imaging, in my mind, will continue to revolutionize how we provide procedural image guidance. And I'm going to share with you one example, which actually happened to be our 500th MitraClip case that we did at the beginning of November, which was an extreme P1 prolapse, as you see it on the left-hand side. And I indicate in red the utility of this multiplanar real-time tool, where I have used the red plane now to perfectly orientate the alignment of an anterior leaflet that would be sufficient for a grasp, and the posterior P1 prolapse as it's indicated with the yellow arrow. The red lines in the dotted line at the bottom indicate the clip orientation, with the 3D image being an en face view. So we're talking about 2 o'clock, 8 o'clock orientation. The right side image now shows how the clip hovers over the mitral valve in exact that same orientation before we go in and then actually achieved a very successful grasp. So I hope this helps to illustrate the utility of such live or real-time multiplanar imaging to plan the procedure and then also guide the procedure. And with that, I thank you for your attention.
Burkhard, that was amazing. I think the just a really wonderful use of 3D and X-plane and multiplanar right at the points where it's so valuable for during the procedure. I think that it's exciting to see that last slide and really think about how multiplanar is going to revolutionize structural imaging. And I think that we're just really learning how to utilize it. And I think there's still some additional software and hardware advances that can come along from multiplanar, because even in that image, there's a lot of stuff that we're looking at that we don't need to see. So if we could have that area cut away and really just decrease focus on that sector exactly where we want to see, and taking that 3-dimensional image and making that the 2D image that we absolutely need for that part of the procedure is just fantastic.
The one point I made during the presentation I think is important to maybe repeat is, if we have a good 3D image, we can use it to deconstruct to 2D and really get the image plane in 2D that otherwise might be harder to find. And that's true for when we're looking for a cleft, or it's true for when we're looking for a very commissure pathology, as in this last example.
Just one quick question about the controlled gripper actuation. So in those maneuvers, when you've grasped the anterior leaflet in your case, and then grasping the posterior leaflet, what are you paying attention to, or what are you doing to make sure that there's no twisting, that you're not moving either lateral or medial from the coaptation point where you'd like to grasp, so you don't alter how the coaptation line comes together?
Yeah, that's an excellent question. I think a lot of things are going on when we use that unilateral grasping, and we have to really be completely alert and focused at that point, because as you say, you can, on the one hand, put enormous tension on the leaflet that you got first. So for that, I think it's important for us as imagers to look at the length and the potential slack of that leaflet. So if we get it first, how far can we actually tense it and have opportunity to move, let's say, posterior if we get the anterior leaflet first. The next is, and I think I briefly mentioned, which is the orientation of the clip. And what we often see, depending on how perfectly we have been set up for perpendicularity beforehand, is that this perpendicularity and the orientation of the clip may change as soon as you have, the gripper down on one side. And so going back and forth between either biplane imaging and 3D, or having this multi-view opportunity where you have a multiplanar assessment with the 3D, if the resolution is good enough for that, all of those help to kind of monitor that closely, so you're not coming in and then ending up with a grasp that may actually distort the valve. So I think the best suggestion is to go back and forth between 2D and 3D imaging to prevent that from happening. And certainly in the elder patient population, if we go above 80, or we have patients where we know they've been on steroids for an extended period of time, then we are even more cautious with putting too much tension on these leaflets.
Yeah, great points. I think one question that often comes up is, how do you manage the breathing as you're managing the vent during these procedures? So especially around grasping or around orientation, are there techniques that you find useful to decrease translation of the heart or improve grasping?
Yes, as an interventional echocardiographer and cardiac anesthesiologist at the same time, that's a very natural question for me. I can just do that, or affect the ventilation with the help of my nurse anesthetist or trainee that I'm working with. Essentially, best recommendation is to reduce the tidal volume significantly, maybe to 300 milliliters or cc's, and then correct with a higher respiratory rate. Often with that maneuver, you don't see as much of a swing. In more extreme situations, we may at times hold the ventilator, but I would say that's 1 out of 50 cases where maybe that's needed, as long as we're mindful about the tidal volume as such.
We found that successful as well, just decreasing down to around 300, and that's been helpful with less motions for sure. Excellent. That was just a really great talk. I think so. Now the clip's in, and procedures. Everyone's, oh great, the MR is gone, and we're all done, right? But no. So Richard, you're going to talk a bit about post-clip echo assessment. And Richard, do you want to take it away?
Yes. Okay. Thank you. So the clip's in. Everybody wants to leave the room, but before you can do that, we do need to check some things out. Here's my disclosure slide. So in addition to just the residual MR, there are several things you want to look at. The clip location. Did you actually place the clip where you intended? For example, if there was a flail segment, did you actually capture the flail? What's your residual gradient or mitral valve area? Of course, what is the residual mitral regurgitation severity? And also don't forget to take a look at the transeptal puncture site. So in terms of clip location, that's pretty straightforward. Did you place the clip where you wanted to? This is easily assessed intraprocedurally with TEE. So in this example, we have a nice tissue bridge between A2, P2, but you can see that there's a flail segment just medial to the clip. This is a situation where if the mitral valve gradient allows you to, you may want to consider placing another clip just medial. So in addition to the clip location, you want to look at the gradient across the valve. So oftentimes we get asked, which orifice do you measure the gradient through? Well, your E and A wave may vary between the different orifices, but the mean gradient should be the same. Doesn't matter as long as you align the cursor to be coaxial to the inflow. So that's an important step. The mitral valve area, we usually go more by the gradient, but you can measure the mitral valve area post-clip. You can planimeter from a 2D transgastric view. You can use the 3D zoom if the bottom of the zoom box is at the leaflet tips, or the most accurate would be using 3D multiplanar reconstruction. This is not so easy to do, obviously by transthoracic echo and follow-up. So mitral regurgitation severity, pre-clip, you all are familiar with the measures that we use: color flow, vena contracta, PISA, quantitative Doppler, pulmonary vein flow reversal are all at our disposal to kind of put together to assess severity. But once the clip is in, vena contracta and PISA are really not as helpful or as valid, and there's no acute change in the LA or LV size. So we're left with looking at other measures of severity. So just as with pre-clip, there's the obvious trivial or mild residual, and there's the obvious significant residual regurgitation, which you probably don't need to equivocate more about. But there's many cases where it's kind of in between, and that's where additional measures other than just color are helpful. So this is just an example post-clip. Here on the left, we see there's really just trivial residual regurgitation, and we don't need to worry so much about quantitation. Of course, you want to visualize this in multiple views, just making sure you're not cherry picking your view. But on the right, we can see that we obviously have some significant residual regurgitation that will likely require additional treatment. Other things you can look at are the pulmonary vein reversals. So if you have significant pulmonary vein reversals in the beginning and this turns to forward flow, you know that you've significantly impacted the mitral regurgitation. So this is an additional measure you can look at, as is the left atrial pressure. With the new G4 systems, you can continuously monitor LA pressure. And if you significantly impact that LA pressure and reduce the V wave, then you have additional confidence that you've significantly impacted the mitral regurgitation. As mentioned before, with the newer systems and with multiplanar reconstruction, I think 3D vena contracta area is a very promising measure. And we can do this pre-clip and post-clip. This is an example from the guidelines showing that this can be very helpful when you have a non-circular orifice. On the left-hand side, the color looks similar between the top and bottom, but you can see that we have a very crescentic orifice with the secondary MR, and that we end up having a larger vena contracta area. And so this can be done again pre-clip, and it can be done post-clip. And Dr. Mackensen's group has published their experience with this, that you can use multiplanar reconstruction to get the vena contracta. You measure the different jets. This example has 2 residual jets, and you add the area up together, and they found that their cutoff to separate moderate or greater and less than moderate was 0.27 centimeters squared. So with the newer systems, this can be done on cart, and actually, can be done relatively quickly if you get some practice with it. And this is another group who published on this, just confirming, and they got a cutoff of 0.25. So it is a feasible technique with newer systems. It takes a little bit of practice, but I think can be helpful when you have some borderline situations where you're deciding whether to leave it alone or go for additional therapies. Another quantitative technique is the quantitative Doppler. And here we see that, and this can be done on all the routine measures of echo in follow-up. You take the biplane volumes and calculate the difference in systole and diastole, and then you get your stroke volume through the LVOT, which is standard, and then you can subtract the volumes. And this is, you have to have, you can't have any significant aortic regurgitation, but in the absence of significant aortic regurgitation, this will give you a relatively quick mitral regurgitant volume and regurgitant fraction. So pre-clip, from this image that we usually rely on PISA for quantitation, but there's obviously severe MR and obviously mild MR. We can use vena contracta, and we have all the tools to look at, but post-clip, we can't really rely on VISA or 2D vena contracta, and that's where for quantitation, 3D vena contracta or the quantitative Doppler can be more helpful. But we still have the other adjunctive things we can look at, such as the pulmonary veins and color flow. So again, color Doppler, it can be helpful if you have obviously trivial or mild or obviously significant regurgitation. You don't necessarily need to go much further than that, but you have your pulmonary veins to look at, you have the LA pressure to look at, you have your quantitative Doppler if you don't have any significant AI, and you have 3D vena contracta area in your toolbox. So the cutoff is somewhere between 0.25, 0.27 centimeters squared. And finally, don't forget to look at the transeptal puncture site. The standard practice is to generally leave this alone, and it usually will close off or remain small. But if you have a tear or large ASD, as in this case, or evidence of right to left shunt, you can see in the bottom right, there is some bidirectional shunt. This is a situation where you might want to consider ASD closure, as long as you're sure that you're not going to have to go back in across the septum for another procedure. Thank you. I did not talk about the post-procedural transthoracic echocardiogram. This is typically a standard transthoracic echocardiogram the following day pre-discharge for your typical MR assessment. We don't repeat TEEs prior to discharge. Sometimes, depending on your hemodynamics in the intraprocedural setting, the mean gradient may be slightly higher on the pre-discharge echo if they were somewhat lower blood pressure during the procedure. So this is just something to keep in mind when you have a borderline mean gradient after your clips. Sometimes, again, depending on the hemodynamic settings, the color flow may look up to a grade worse in the pre-discharge transthoracic, but that's where the other, the intraprocedural assessment, LA pressures, pulmonary vein reversals are important to kind of give you confidence that you really did help that patient.
Great. I think we could open it up kind of for discussion. Any other, any just general topics or general experiences with the G4 system? Any other questions or things you wanted to discuss?
Let me ask Burkhard, does your institution have any experience using trying to get the 3D vena contracta by transthoracic echocardiography in follow-up? It just seems like that would be very technically challenging, but I just wonder if you have looked at that or use that routinely.
I think the general question about interprocedural final results based on TEE with the patient still under general anesthesia, and then going to a post-procedural transthoracic echo and the comparison on the next day is a topic that will be discussed forever. And it's hard in many ways. The transthoracic echo, often in these previously operated patients, is challenging, and getting good enough high quality 3D color images to then find what now often is then a very small vena contracta area. And as you've demonstrated, we often see almost just like small little pixels, even with the TE 3D color assessment. And so that's even more compromised with TTE. So we're not asking for that. We're trying to explore it. I think if it really works, then that's a bad sign, meaning the vena contracta area will likely be large enough so that further intervention may be needed. I hope that answers the question.
Yeah, I wonder how in the post-procedure echo, how the 3D volumes are going to play perhaps a stronger role moving, because now the 3D transthoracic has advanced significantly for ability to assess LV volumes, and perhaps that will we'll move more toward that quantification of regurgitant volume, regurgitant fraction post. I think we haven't really used that as frequently as I think the advances in technology may allow us to do in the future. So perhaps we'll use even a slightly different or a different method to quantify the regurgitation. And I think I usually read them both, so there's probably a study in there. Looking at the day one echo versus the procedural echo.
One question that I would have is back to the question that always comes up, which is, how much of a gradient can we tolerate? And I think more recent co-op data for longer term have indicated that perhaps there's a little bit more room than we initially thought. Often the cutoff was 4 millimeter mercury, and definitely not more. And there's certainly some evidence from smaller studies to support that. But the more recent co-op trial data, as I understand them, have indicated not as much of a negative impact, even if we reach maybe a 5 or 6 millimeter mercury. Any comments on how you're assessing it intraprocedurally versus then post?
From our standpoint, we're trying to individualize it for the patient, and then also trying to weigh the reduction in MR to the change in gradient. So if it's a second clip that raises the gradient from 4 to 5, but reduces the MR from moderate to trivial, then we probably would take that change. If it's a decrease from 1+ to trace, or some from mild to gone, and it comes with an increase in the gradient, and obviously we wouldn't make that change. But I think we're trying to weigh it from the MR is probably, the residual MR is probably going to drive the morbidity. And if we can cut the MR significantly at the expense of a 1 to 2 millimeter gradient, then we're generally willing to do that and think that that's favorable for the patient. The age of the patient, the activity of the patient, the heart rate of the patient comes into play as well. So a patient in their early 90s who's not that mobile, maybe we would tolerate a slightly higher gradient, as opposed to someone in their late 70s or who's going to be more physically active. And we anticipate, just like a patient who has a mitral valve repair, that with exercise their gradient may increase significantly. So individualized, but we're putting a lot of our assessment on the improvement in MR, what benefit we're going to have there or not. And if it's not significant, then we wouldn't attempt it.
Yeah, I think we would follow a similar approach, trying to tailor it to the patient's age, activity level, and looking at their heart rate, et cetera. So I think we would follow a very similar approach, kind of in an elderly patient, not so active, tolerate a higher gradient to get a better reduction in MR.
Good. I think one comment I would like to just add in general, I think all three of us are in a great position to have interventional proceduralists that really look to us and work with us in concert to obtain the best result in the end. I would like to encourage everyone out there, and at the same time hoping that interventional proceduralists will actually, cardiologists will watch this part of the segment as well to learn from us. But I would like to encourage everyone to really reach out and try to illustrate the value of echo guidance in this procedure. And many insightful interventional cardiologists will agree that the improvement we've seen on the imaging side have really allowed to treat outside of regular pathology and go beyond the A2 and P2 pathology and be more innovative in terms of approaches. And having these several collections for clips has certainly supported that. So I believe it's really important to have an optimal communication.
And I think one thing that you said during your talk, Burkhard, about predicting or anticipating the next step for the interventionalist, goes a long way in building that relationship. So when the interventionist looks up and she sees, oh, okay, the next step is right in front of me, and I know exactly what the next manipulation of the catheter is, because I know that advancing the catheter or moving it medially is safe in this position. I'm seeing everything that I need to see, and after a while, at least there is minimal discussion related to the procedure, because you're actually talking through the images. And there's that back and forth in the lab, and that relationship is so important, and making sure that you have that link. And I think having that link so that they see what they need to see without asking for it, or it's seamless, that goes such a long way in building that relationship.
Yeah, I agree. It's we joke that sometimes it's like an old married couple, you know, we don't talk, but we're kind of on the same wavelength. And I would also say that, you know, the advances in imaging, you know, have made it a much more relaxing procedure, and we feel a lot more confident in letting go and making small, fine adjustments to optimize the result. Whereas before, you know, you just wanted to get the leaflets in and, you know, call it a day. And I think that with all these advances, you know, slight optimizations can make a big difference. And, you know, I think you shouldn't be afraid to, you know, let go and move it a millimeter or two, and it can make a big difference sometimes.
Yeah. Sometimes what I find is super helpful, especially if you're teaching someone to do the imaging, position yourself on the interventional cardiologist side and spend a couple hours there and watching what's happening, and you know, the sequence of images coming up and the anticipation will be greatly appreciated if you're on the other side of the procedure.
Yeah, absolutely. Well, I'm certainly looking forward to the next few years and what else is going to come forward, and what we can be a part of. So it's been just an excellent discussion, and thank everyone for just participation and a great discussion.